Dear colleagues, on behalf of the European School of Oncology and We Oncologists, I would like to welcome you to this first of our educational presentations from We Oncologists and ESO Presents. My name is Gilbert Morgan. I work in medical oncology in Sweden, and today I will be giving a presentation entitled Optimal Management of Pain in the Adult Cancer Patient. These lectures are all initiative to promote global oncology education, so please feel free to share us. You can feel free to follow us in our Facebook page, our Twitter account, and of course you can always follow me at Gil Morgan at We Oncologists. I have no conflicts of interest. So in the development of the following presentation, I used the ESMO clinical guidelines for the management of cancer pain in the adult patients. These are well updated and were released in 2018 and can be downloaded for free at Annals of Oncology. During this presentation, when you see the ESMO Clinical Practice Guidelines banner, this means that this is directly from the ESMO guidelines. Any slide that does not have the banner, it is not directly from the guidelines. There are many things that we need to take into consideration in the assessment of pain. First of all, in order to talk about pain, we need to learn to recognize pain. And we have to have a sort of scale to assess it. 3 good tools that can be used are the visual analog scale, the numeric rating scale, or the worst pain question when we ask our patient what the worst pain they have had and how pain relates to that. There are, however, situations where our patient is cognitively impaired. So these tools might not be a really good way to assess this. So we need to observe pain-related behaviors that could give us an idea. A good example is facial expressions such as frowning, grimacing, distorted expressions, or rapid blinking. Another aspect of pain that is often missed is the psychological impact that cancer plays in our patients. We have to remember that the psychological burden could lead to depression, stress, and anxiety. And our patients are going to need help with this too. So the help could start with medications, but it will no doubt lead to required support. Remember that there is no I in team. As a doctor or a nurse specialist, don't take the role of a one-person show. Pain management is a team effort. Just as it's necessary for nurses and doctors to communicate, it is of dire importance that we have a good communication with our patient. However, to take it one step further, we should be encouraging our patients to have an active role in his or her pain management. Through this, we can positively affect the mindset of the patient and quite possibly affect the amount of medication that is required to treat. Cancer pain is both acute and chronic. So once you know that there's chronic pain, around-the-clock administration of pain medication is needed. This is done in order to prevent the onset of pain, and you should not have as required doses, but rather you should have pain management on a regular basis. Along with this, a required emergency dose of quick-acting pain medication has to be set. The oral administration of pain medication should always be advocated as a first choice. Cancer pain is a common complication of cancer diseases. Because the nature of the disease is chronic, cancer pain is a common cause of chronic pain. It is not enough that a health professional is equipped to assess pain. The patient and their families must also be educated, and they need to know the proper use of pain medications. And of course, it concerns regarding the side effects and addictions that could come up because of those medications. Through open communications between the professionals and the patients, the detection and the treatment of pain could be an easier process. As we said, there are different tools that we can use, as we see the visual analog scale, which you see there's different kinds of phases, from a frowning face that's crying to a happy face. This is actually a really easy thing to have with you all the time. And even if your patient can't communicate with you, you can always pull this out of your pocket, and the patient can point to how he or she feels. There's also the numeric rating scale and the verbal descriptor scale. There are different types of pain, and each have different characteristics. Somatic pain is a kind of nociceptive pain that is also referred to as skin pain, tissue pain, or muscle pain. The nerves that actually detect the somatic pain are located in the skin and the deep tissues. We have neuropathic pain. This is caused by damage to the somatosensory nervous system. This kind of pain could be associated with abnormal sensations called dysesthesia. This is when one has pain from normally non-painful stimuli. And this can be pain that can be continuous or episodic. Visceral pain is a pain from the activation of nociceptors of the thoracic, pelvic, or abdominal organs. These are very sensitive to stretching, ischemia, and inflammation, but relatively insensitive to other stimuli such as cutting and burning. Like we mentioned, pain can either be acute or chronic. The World Health Organization has developed a 3-step ladder for cancer pain relief in adults. When pain happens, there should be a quick oral administration of the drugs as follows. In step 1, use non-opioids such as aspirins and paracetamol. In step 2, you use step 1, the non-opioids, plus mild opioids like codeine. In step 3, you use the non-opioids from step 1, but also strong opioids such as morphine. And you treat until the patient is free of pain. In the treatment of mild pain, non-opioids such as aspirin or paracetamol are our first choice as indicated by the WHO analgesic ladder. It is worth remembering that NSAIDs and paracetamol have a ceiling effect, and there is no therapeutic gain from increasing dosages beyond those recommended. So once you have reached the highest recommended dose, it's time to move on to the next step. As there is no clearly superior NSAID, the choice should be based on experience and the toxicity profile of every NSAID. In the treatment of moderate pain, weak opioids like tramadol and codeine can be used, and this should be combined with non-opioid analgesics such as paracetamol or ibuprofen. There is an alternative which is often practiced, but it's not in the WHO pain relief ladder. And this is to hop over step 2 and instead replace it with low doses of strong opioids. Although this is not in the relief ladder, the ESMO guidelines saw no adverse effect with this practice instead of the second step in the approach. The body uses naturally occurring endorphins to kill pain, and opioids give us a similar effect. They block the messages of pain that travel along from the nerves to the brain. This morphine is the most commonly used opioid and the one where patients have a tendency to achieve the most adequate pain management. There's different ways to administer morphine, such as tablets, liquids, injections, patches, and suppositories. When we start morphine, we always start with a short-acting morphine, and the reason we do so is because it's easier to adjust the doses. Once the pain is under control and we know how much morphine that patient is taking, we can change it to a long-acting, slow-release tablet or capsule that would give us the right amount of morphine. These long-acting morphine tablets will last around 12 to 24 hours per dose. So we normally give them around 8 o'clock in the morning, 8 o'clock in the evening. With moderate to severe cancer pain, oral morphine is the opioid of first choice. The average relative potency ratio of oral to IV morphine is between 1 to 2 and 1 to 3. The average relative potency ratio of oral to subcutaneous morphine is between 1 to 2 and 1 to 3. Once we achieve a point where adequate analgesia is not achieved, despite the escalation of doses, one shouldn't be afraid to switch the opioid to something else. Other options to morphine can be fentanyl and buprenorphine via transdermal or IV route. These are the opioids that are the safest in patients with chronic kidney disease, stages 4 or 5. Fentanyl is a type of opioid, and it can also help in controlling breakthrough pain. There are a variety of ways of delivering fentanyl, such as patches, lollipops, tablets, and nasal sprays. In talking scheduling and titration, individual titration needs to be done. Normal release morphine is administered every 4 hours plus rescue doses for breakthrough pain. It is recommended in the clinical practice. Immediate and slow release oral morphine formulations can be used to titrate the dose. Titration schemes for both types of formulation should be supplemented with immediate release oral opioids prescribed as required for breakthrough pain. The regular doses of slow release opioids can be adjusted to take into account the total amount of rescue morphine. So the administration of pain relief with moderate to severe pain, this is the subcutaneous route is very simple and effective for the administration of morphine, diamorphine or hydromorphone, and it's the first choice alternative for patients that are unable to get oral opioids or transdermal. An IV infusion can also be considered when subcutaneous administration is contraindicated. This is such as in the cases of peripheral edema, coagulation disorders, poor peripheral circulation, and need for high volumes of doses. So IV administration is an option for opioid titration when rapid control is needed. So this is an example of an opioid dose conversion chart. This particular one was borrowed from the NHS, but variants of the same can be found in your respective countries. I will not go through it in detail, but it is a great tool to have because opioid conversion is something that is done often, and it's something that needs to be done right to provide the best amount of relief. Points to remember are that breakthrough pain requires a dose that is 1/6 of the daily morphine requirement. So calculate it and always have it handy. In patients with renal failure, consider fentanyl patch or oxycodone. When dealing with fentanyl patches, change the fentanyl patch every 3rd day or 72 hours. And be clear with the instructions with your patients. It's not uncommon that you have a patient or a patient's family show up and the patient has 3 patches stuck to his or her skin, and it's it needs to be just one patch or the patches that are required. In the management of opioid side effects, opioid-induced constipation is a common situation and laxatives must be prescribed before the problem starts. However, it's not just opioids that can give constipation and eventually pain. Certain chemotherapeutics and antiemetics can do the same. This can eventually manifest itself as pain and nausea. Naloxone blocks the effects of opioids and is used especially when a quick reversal is necessary, such as in the cases of an overdose. It can be given intravenously, and when done so, naloxone works within 2 minutes. And when injected into the muscle, it works around in 5 minutes. This can also be combined in a tablet in order to offset some of the effects of opioids. Naloxone, or the trade name Moventig, is a peripherally selective opioid antagonist that can be used for the treatment of opioid-induced constipation. When you give it concomitantly with opioid analgesics, naloxone can reduce constipation-related side effects while maintaining comparable levels of analgesics. Ondansetron can prevent nausea and vomiting caused by chemotherapy, radiation, and surgery. And it's also useful with gastroenteritis. However, it has very little effect when it comes to vomiting caused because of motion sickness. This can be given by mouth or by injection. Methylphenidate, or Ritalin, which is a stimulant, used to treat attention deficit hyperactivity disorder, and narcolepsy, can be, it's for opioid-induced sedation, but it's only advised when other methods to treat have been tried. Breakthrough pain can happen suddenly, and it can be extremely severe. It might be because of movement or activities, or it can also be unexpected and happen for no apparent reason. We need immediate release opioids. These are what should be given in order to treat breakthrough pain that is opioid responsive and for which background cancer pain management has been optimized. Transmucosal fentanyl formulations can be used. They have a big role in unpredictable and rapid onset of breakthrough pain. Normal release opioids can be used in situations where there is a slow onset of breakthrough pain. And another option is to give oral opioids a half an hour before the predicted breakthrough pain occurs. Approximately 2/3 of patients have bone metastasis. 2/3 of the patients with bone metastasis have severe and debilitating pain, and radiotherapy can relieve this kind of bone pain. Radiotherapy is often used to control pain due to bone metastasis secondary from prostate cancer, breast cancer, bowel cancers, or lung cancers. Radiotherapy can help make these bones stronger and less likely to break, and it can even treat fractures. So radiotherapy for cancer that is spread through the bones can also help prevent new painful areas developing. External radiotherapy is the most common type of treatment if you have just 1 or 2 bone secondaries. The radiation beam is directed at the affected bone from outside the body. External radiotherapy for bone pain can ease the pain to some extent and may get rid of it altogether. The radiation kills off the cells that are destroying and weakening the bone. It may take several weeks to work fully, but about 3 out of 10 people, around 30%, have absolutely no pain within a month after radiotherapy. The treatment reduces the pain by half for at least another 4 out of 10 people. So at least 7 out of 10 people have somewhere between no pain or half as much pain after radiotherapy treatment. So about 6 to 12 weeks after the treatment, bones have already repaired and the damage that is caused by cancer cells have gotten stronger. So all patients with a painful bone metastasis should be offered EBRT, 8 grays, 1 single dose. And of course, it is possible to give re-irradiation with recurrent bone pain. Stereotactic radiotherapy is a different modality that gives radiotherapy from different positions around the body, with all beams meeting at the tumor site. The tumor is able to receive a high dose of radiation, and the tissues around it only receive a low dose, and this lowers the risk of side effects. This is done with patients with oligometastasis who have good performance status and well-controlled primary sites. Stereotactic treatments can also treat areas that have previously been irradiated. For example, someone with previous radiation to the pelvis would not have radiotherapy again, but because of the precision of stereotactic radiation, it can be retreated. Many solid tumors metastasize to bone, leading to debilitating skeletal complications such as intractable bone pain and pathologic fractures. The majority of skeletal metastases are from prostate and breast cancer and have skeletal-related events. Radium-223, also known as Xofigo, is a mildly reactive form of the metal radium and is effective in reducing the skeletal-related events, decreasing the pain, and improving survival. Xofigo is mostly used for prostate cancers that have skeletal metastasis. Radium is very similar to calcium, and much like calcium, it can activate bone cells to take up the radium. Once the radium is in the bone, it releases the radiation, and the cancer cells receive a high dose of radiation. Strontium is another option which takes between 1 to 4 weeks to start to reduce the pain. However, the pain relief may last up to 18 months. Biphosphonates are the standard care for the reduction of skeletal events associated with bone metastasis. Among metastatic breast or prostate cancer patients, zoledronic acid has been demonstrated to significantly reduce the pain and skeletal morbidity. They may be considered as a part of therapeutic regimen for patients with bone metastasis and a good prognosis. Biphosphonates are a particularly good option in situations where there is no access to radiotherapy or the pain is not localized. However, it is important to note that before starting bisphosphonates, preventative dental measures need to be taken. Among patients with metastatic breast or prostate cancer, zoledronic acid has shown reductions in pain and skeletal morbidity compared with placebo. Denosumab is a human monoclonal antibody that specifically binds and inactivates an important ligand that regulates bone remodeling. This can be a good alternative to biphosphonates in metastatic bone disease from solid tumor and myeloma. In several trials, denosumab significantly reduced treatment-related osteoporosis associated with breast and prostate cancer and was superior to zoledronic acid in prevention and delaying of skeletal-related events. Much like biphosphonates, preventive dental measures is necessary before starting. Malignant spinal cord compression occurs where cancer grows in or near the spine and progresses in the spinal cord and nerves. Early diagnosis and prompt therapy are powerful predictors of the outcomes in malignant spinal cord compression. The symptoms of MSCC are back or neck pain, numbness of pins and needles in your toes, fingers, or buttocks, feeling unsteady on one's feet, and bladder and bowel problems. The majority of patients with malignant spinal cord compression should receive radiotherapy alone, but surgery should be considered for selected cases. So you need to contact your onco-orthopedic surgeon and have a discussion with him or her. Decompressive surgery followed by long-course radiotherapy may be offered for appropriate symptomatic MSCC patients, including spinal instability and displacement of vertebral fragment. Cancer-related neuropathic pain is very common. This pain can be disease-related or related to the effects of the chemotherapy. The effects that happen from some chemotherapy affect around 90% of the patients receiving a neurotoxic chemotherapy. Neuropathy has become a more complicated problem, and the key component in management is assessment. The most important thing with neuropathic pain that comes with chemotherapy is that we do not miss the window of reversibility and that we stop the treatment before it causes the damage or aggravates the damage. Cancer neuropathic pain can be treated with opioid combinations and adjuvants when opioids alone are insufficient. Patients with neuropathic pain should be given either a TCA or an anticonvulsant and be monitored for side effects. These are gabapentin, pregabalin, duloxetine, and TCA. These are strongly recommended as single agents for neuropathic pain first-line treatment. There is lack of evidence to support the routine use of ketamine in cancer neuropathic pain, invasive management of refractory pain. In the case of extreme pain that cannot be controlled, intraspinal techniques delivered by a skilled team can be an option. In pancreatic cancer patients not eligible for operation, abdominal pain is a big problem, and it's very difficult to treat. A celiac plexus block is a safe and effective method for reducing this pain through the chemical destruction of nerve fibers that relay the pain from the abdomen to the brain and can provide relief for several months. Cordotomy is a surgical procedure that disconnects selected pain-conducting tracts in the spinal cord in order to achieve loss of pain and temperature perception. Now I would like to go through some practical tips on how pain management can be implemented. Morphine is a standard treatment, but there are some advantages to using oxycodone, such as in patients with impaired kidney functions. The start dose of morphine is 10 milligrams times 4 to 6. Remember to always prescribe laxatives and antiemetics alongside the first time setting of opioids. It is important that we assess the effect of our pain medications constantly. Ask yourself, is morphine providing complete relief for my patient? There are some instances where a 2-dose long-acting morphine is not alleviating the pain, and there is often a possibility to switch to a long-acting morphine that is given 3 times daily instead. The goal in pain management is to have no pain, so the patient should always have pain management in the case of breakthrough pain. 1/6 of the total daily dose of opioids is the required dose for the treatment of breakthrough pain. Something that we all have a tendency to forget is to warn patients not to eat grapefruit or grapefruit juice, as grapefruit can react with fentanyl and oxycodone. This may increase the amount of fentanyl and oxycodone that circulates in the bloodstream, And a similar reaction is actually seen with the chemotherapy vincristine. So practical tips and implementations for mild pain. Paracetamol is the basis or the foundation for all cancer-related pain treatment, and the recommended dose is 4 grams per day. A good complement to opioids are NSAIDs, and these normally are a big help when it comes to pain that is associated with movement or pain that is dependent on an increase in pressure, such as pain from liver metastasis, a type of capsular pain. So please remember that with our older patients, heart and kidney failure cannot really tolerate these kind of treatments in full dose. So control the thrombocytes, and we normally have as a standard to prescribe omeprazole 20 milligrams times 1 to protect the stomach lining. When it comes to neurogenic pain, amitriptyline, gabapentin, and pregabalin can be used to can take time to actually take effect. So in emergency situation with neurogenic pain, always start with injectable morphine or oxycodone and wait for amitriptyline, gabapentin, or pregabalin to take effect. These can give tiredness, ataxia, and dry mouth. So you always want to start with a low dose. So you can start, for example, amitriptyline at 10 milligrams at night, and then you can slowly start to increase. With fentanyl and pumps, we know fentanyl is often what we see is a fentanyl patch, which will give you a certain, or will give your patient a certain level of freedom with less constipation and nausea. However, we have to be sure that the patch is making the required contact with the skin. If it's not making the required contact with the skin, you're probably not getting the right amount of drug delivery. So you can have a patient that still has pain and you're increasing the dosages, and then when you look at it, well, the patch is not making contact. This often can be the case when there's a lot of edema. So be sure to remind the patient to make sure that when they set the patch, it's making contact, and of course to always remove the old patch every 3rd day when they set in the new one. If once opioids are started, one sees unacceptable level of pain management, we can't be hesitant to switch the opioids to something else. When the patient is in a situation where larger doses of opioids are needed, there is always the option to set in a pump, for example, a hydromorphone pump. However, we do this with the help of a pain specialist or a palliative clinic. In the cases of pain, anxiety, and nausea, think about what kind of pain your patient has. Is it new? Where is it coming from? Describe the type of pain. What is the intensity level? Is there anything that alleviates it? Is there anything that aggravates it? Steroids can be used as analgesics with symptoms of pressure. In the case of skeletal metastasis, sometimes a low dose of betamethasone between 2 to 4 milligrams can help under a short amount of time. However, you eventually have to decrease the doses and set it out. When experiencing anxiety or depression, we can start with benzodiazepine and alprazolam. They can have a good effect. But as I said, often this requires also support for the patient. So little practical tips on the implementation of nausea. Around half of our patients with advanced cancer have some form of nausea. So this is quite a common situation. Many medications can cause nausea, such as chemotherapy, opioids, antibiotics, etc. So the first thing we do, you remove all the medications that can be removed for the patient when you have them in, because you don't know exactly what's causing the nausea. A change in electrolytes can also affect nausea, such as hypercalcemia, ketoacidosis, or kidney failure. So try to treat the primary reason before you try to alleviate the nausea. When introducing morphine, introduce metoclopramide during the first few days in the case of nausea. So you can use oral or injection of Primperan from 10 to 20 milligrams 1 to 3 times a day. When given chemotherapy, always treat the nausea prophylactically and make sure that the patient has a right amount and type of antiemetics. When it comes to acute nausea caused by chemotherapy, use 5-HT3 receptor agonists such as ondansetron, granisetrol, and tropisetron. If these do not give the adequate effect, try palonosetron such as aloxi. The only problem with aloxi is that it can give an extreme constipation, so make sure that you always prescribe laxatives. Cortisone can also have a good effect in the treatment of nausea. So there are many uses to steroids in cancer. In the case of malignant spinal cord compression, dexamethasone 60 milligrams daily can be administered to symptomatic patients. In the case of brain metastases, which are most common with breast, lung, and kidney cancer, be on the lookout for people that are coming to you with headaches, nausea, and neurologic problems. This would require immediate treatment with high-dose cortisone, 8 milligrams times 2 daily, and of course contact with a neurosurgeon. Once you do a CT or an MRI, you start the patient on betamethasone, normally 8 milligrams at 8 in the morning, 8 milligrams at 2 in the afternoon. Remember not to set the time of administration too late so that the patient is not completely wired and he or she can sleep. In the case of extreme brain edema, give an initial dose of 16 milligram of betamethasone. In the case of no brain metastasis on a CT, order an MRI and check for meningeal carcinomatosis. Often when it comes down to brain metastasis, single brain metastasis can be treated with stereotactic radiation, and multiple brain metastases often radiate the whole brain, 4 grays in 5 fractions. So when it comes down to constipation, constipation sometimes can be caused because the tumor is growing in a way that is affecting the GI tract and causing the nausea. It can be a slow emptying of the stomach and a decrease in the peristalsis. And this can be helped by the use of metoclopramide. In the case of gastric retention, you can set a nasogastric tube, and this would give you quite adequate relief. With a blockage that is quite low, one can try haloperidol, or an anticholinergic such as Buscopan, or an antihistamine such as Postephen. Cortisones can also have an effect with nausea in the case of ileus and subileus. So these are the take-home messages. There should always be an open discussion with the patient. Encourage your patients to have an active role. Don't forget to always have a copy of the VAS and NRS pain scale in your pocket. Don't neglect the psychological distresses that come with cancer. Prevent pain with around-the-clock administration of drugs always. Chronic pain should be treated on a scheduled basis. Don't forget how to use the WHO pain relief ladder. Always start with paracetamol. You have the second step, which is the paracetamol and weak opioids, and the third step, paracetamol and strong opioids. And know that step 2 can always include low dose of strong opioids. The first choice, opioids, is oral morphine. Breakthrough pain requires 1/6 of the daily morphine dose. Always know how to convert oral, IV, and subcutaneous morphine. My tips is have a copy of the conversion chart in your pocket. In patients with kidney disease, use fentanyl or oxycodone. Patches must be changed every third day when you're dealing with fentanyl and must have a good skin contact. Opioid switching, if you're not having the desired effect with the opioid you're using, is highly recommended. Subcutaneously delivery is simple and effective and a good way to administer opioids. Use IV when subcutaneous administration is contraindicated, such as in the cases of edema, coagulation, or when high doses are needed. Laxatives are always needed with opioids. Naloxone, when used promptly, can help you in the cases of respiratory depression that are caused by opioids. Titrate naloxone before administering. Metoclopramide and antidopaminergic drugs for nausea can be used. Breakthrough pain, always use opioids and fentanyl and know how to predict the breakthrough pain. Painful bone metastasis can be irradiated with 8 grays, single dose, and recurrent pain can be re-irradiated with a further 8 grays. Xofigo can decrease skeletal-related events in patients with metastatic prostate cancer to the skeletal system. Malignant spinal cord compression needs early diagnosis and contact with the onco-orthopedic surgeon. Radiation of the malignant spinal cord compression. Start dexamethasone or betamethasone quickly. Biphosphonates in bone metastasis and have a good prognosis. Denosumab delays bone pain fracture and has shown to be better than biphosphonates in many instances. Always take preventative dental measures with denosumab and biphosphonates. Neuropathic pain can be treated with opioids. First-line treatment of neuropathic pain, gabapentin, pregabalin, duloxetine, and TCAs. Remember that it takes time to see an effect with neuropathic pain. When you're dealing with gabapentin, always treat with morphine IV in acute situations. Intraspinal techniques such as sclerotomy and celiac plexus block work in cases where you cannot control the pain. The start dose of morphine oral is 5 to 10 milligrams, 4 to 6 times a day. If 2 long-acting doses are not working in morphine, you can switch to 3 doses a day. Paracetamol max dose, 4 grams per day. And NSAIDs can be used for pain that comes from movement, but check the thrombocytes and see about setting in omeprazole at the same time. When higher doses are needed, start taking contact with a pain specialist or a palliative clinic so you can start use of a pain pump and changing to maybe hydromorphone. With nausea, you can always try Primperan, 10 till 20 milligrams 1 to 3 times a day. So that is my presentation for the day, and I thank you very much for your attention. As I said, I used the ESMO guidelines for a good bit of this, and of course using other tools and my own personal experience. If anybody has questions, please feel free to email me. But pain management is something that we as doctors need to be better at. Often we deal with it daily, and because we deal with it daily, and it's one of the aspects of patient care that really could affect our patient's life in a big way, because the cancer comes with a lot of pain. So we need to do this. We need to be good at pain management, not only for us, but for our patients. So I thank you so much for your attention. I hope you enjoyed the lecture. And please, if you have any questions, comments, or feedback, don't hesitate to contact us.